name is Misty Blevins with the National Rural Health Association, SC. I want to take this opportunity to welcome each of you to today's webinar, Understanding Clinical Telemedicine for Rural Applications. We are unable to provide CEUs or CPEs for this session. Certificates of attendance will be available upon request for attendees who register, attend the entire webinar, and participate in poll and survey questions. Attendees may use these certificates with third-party organizations or their employer as documentation of having received an hour of webinar instruction. NRHA partner educational webinars are recorded, and an on-demand link will be sent in 24 hours to all who registered for the live webinar. Please note that throughout the presentation, all participants will be placed on mute. And I do want to bring attention to the fact that the handouts are available on the GoToWebinar dashboard. If you just click on the little plus sign next to the handouts, you can go there and upload those handouts. So with that, I will now turn the presentation over to Carrie.
Thank you, Misty. I would also like to personally welcome all of you to AMD Global Telemedicine's webinar today. This webinar is intended to help educate you on clinical telemedicine encounters, what they are, how they work, and how healthcare professionals are using them as part of their everyday care model. But before we begin, I just want to go through letting you know if you do have questions throughout the webinar, there's a panel on the right-hand side of your screen that says questions, and you can type in your questions there throughout the duration of the webinar, and then we'll have a 15-minute Q&A session after the presentations to address as many questions as possible. Those that we don't get to, we will also send a follow-up summary for the question and answers, and we'll address them then. If you are having any issues, technical issues with your connection for GoToWebinar, the customer support number is here at 1-800-263-6317. So to help set the stage for our discussion today, we wanted to first share with you some of the many benefits clinical telemedicine provides for rural healthcare. It provides patients who live in rural areas access to comprehensive, high-quality healthcare in their home communities. It offers rural clinics or hospitals a way to provide access to additional medical specialties that they could not offer on their own, perhaps, and it reduces travel expenses and time for patients, which means happier patients who return for more additional care later on. And finally, it gives both patients and providers immediate access to real-time patient care. And so, I'd like to welcome our featured presenters today. First, you'll hear from Riley Normandin from AMD Global Telemedicine, who's going to help you understand what a clinical telemedicine encounter is and how it fits into your clinical workflow. And then we'll hear from the team at Mercy Care Community Physicians about how they have adopted telemedicine in their retail pharmacy clinic to bring healthcare closer to their community. Presenters from Mercy Care include Steph Cooper, Brooke Hensinger, and Kara Gosselin. Riley Normandin is the International Telemedicine Program Design Manager here at AMD Global Telemedicine. And Riley has extensive experience helping customers around the world architect their clinical telemedicine programs. And so today, he will share with you the basic principles of a clinical telemedicine encounter and how it all fits together to help you within your existing workflow. Riley?
Thank you, Carrie. So here we're going to talk about what is a clinical telemedicine encounter. Before we do that, I want to clarify what it is not. Clinical telemedicine encounter, it's not direct to consumer. It's not the wellness apps that you may see on your phone, where it'll periodically ask you to update blood pressure or take pictures and send them to a dermatologist. It's not home health monitoring or anything that you would see directly on your phone. Clinical telemedicine encounter should involve at least 3 people: a consulting physician or specialist, a patient, and a nurse attendant to take direction from the doctor. Also, from an experience point of view, a telemedicine encounter should pretty closely resemble as if you are actually in the clinic or there with the doctor themselves. So that could be anything from a face-to-face communication, maintaining eye contact with the doctor, the use of medical devices depending on what the need is or the chief complaint. So maybe that's incorporating an examination camera to take a close head-to-toe view of the patient, getting a really close-up view of a rash or a wound, taking a look at someone's eye, or perhaps in the ear, or using a stethoscope to listen to the heart and lung sounds from 1,000 miles away. But also using documentation, just as if you're in the clinic, taking vital signs, height and weight, being able to save all this data at the end of an encounter. When done right, a telemedicine encounter should be able to manage that patient before, during, and after the actual exam. So the telemedicine system should be able to adapt to whatever the clinical workflow is that the clinic or the hospital is currently using. So that could include being able to make more efficient use of the doctor's time, reduce wasted or lost time. So perhaps the patient checks in, comes into the clinic. It should be no different, because it's telemedicine, than it is if that patient walks into their GP's office. The nurse can take the patient to the telemedicine room and start preparing them, taking vital signs, collecting some data based on the reason they're there, or an illness, and then make them available to the doctor, so the doctor isn't sitting there, waiting for a telemedicine call to come in. They're resuming, going through their day-to-day responsibilities and seeing exactly when they're needed. Coming full circle, the live telemedicine encounter is really the heart of the system, of course. Being able to have a face-to-face communication and live medical video streams and diagnostic data from the devices. And of course, the last part is saving the data into the patient record. So from the point of view of the patient experience, like I said, it should be no different, or at least closely resemble as if you're really there with the doctor. And the technology today can allow you to do just that.
So for the sake of the demo, we're going to skip the first couple of parts regarding the workflow and getting the patient to when they're prepared for the consult. We're going to focus on the live telemedicine encounter. Here we are approaching it from, I'm playing the role of both the patient and the nurse, and you're viewing it from the side of the doctor. As you can see, when you log in, you want to be able to have an understanding of where the patient is and why they're in the clinic today. So at first glance, you can see some vital signs. You can see the patient ID in the top right-hand corner. And now, to make best use of the doctor's time, the nurse has taken these vitals before you've entered the consult. They've also included some documents that will give you an understanding of why the patient's here. So There's a general patient form, maybe a patient consent form, also an ECG that may have been taken upon the patient's last visit to the clinic. From here, the nurse is now at the direction of the doctor. They're they're an extension of the doctor, so if they want to hear some heart and lung sounds from the stethoscope, they can see where the chest piece is located from the video conferencing on the right, and they should be able to hear very clearly the heart and lung sounds through a pair of over-the-ear headphones. Over-the-ear headphones are recommended so that you can block out a lot of the background noise in a hospital or a clinic. Doctor also has the ability to change the audio filters from their own side. So changing from bell to diaphragm or making the sound louder, adjusting the volume settings. This is critical as the nurse or the attendant is holding the chest piece in one hand, directing the patient with the other. The doctor has the ability to act as the nurse's third hand. Also, within a telemedicine clinical encounter, you should have the ability to take a closer view of the patient using other diagnostic tools, such as a general examination camera. If the patient comes into the clinic complaining of discomfort in their eye or a rash, the nurse, at the direction of the doctor, can give the doctor a really close-up, high-quality view of the eye. Just as would be the case in any hospital environment, the doctor will also probably want to take a look inside the patient's ear. So by changing the medical video source, the doctor can do just that, while simultaneously being able to capture images during the live video and being able to save those into the patient's record at the end of the consult. So any images that are taken, any documents that are provided, whether it be an ECG or an X-ray or vital signs, or perhaps an electronic prescription, the doctor, as well as the nurse, has the power to save that data back to the patient's record at the end of the consult. So at the end of the consult, the data is saved. It's time for the next patient to come into the clinic, and the doctor here would simply clear the session, and the data is erased, so there is no fear of duplicate entry or mixing up the data collected, and the next patient can come into the clinic.
Thank you for that demonstration, Riley. And so next, we're going to hear from, now we'll turn it over to the Mercy Care team, who's going to share with you their use of clinical telemedicine and how they have adopted it to service patients in their community.
Thanks, Carrie. Hi, everyone. My name is Brooke Kinsinger, and I'm the Senior Director of Mercy Care Business Health Solutions here in Cedar Rapids, Iowa. Thank you all for attending today. First, I'm going to tell you a little bit about Mercy so you can become familiar with our market. We are a health system comprised of a not-for-profit hospital, which is Mercy Medical Center, a for-profit physician group, which is Mercy Care Community Physicians, and then also I'm a part of Mercy Care Business Health Solutions, which is under the Mercy Care Community Physicians umbrella, and I'm charged with working with employers and community partners to expand our footprint of our system into non-traditional areas to have better access for patients. So a little bit about Eastern Iowa, if you're not familiar with this region of the country. Cedar Rapids is located in Eastern Iowa. It's a population of about 150,000 residents. Our health system is mainly in Cedar Rapids, Iowa, and the surrounding communities. Some of those are rural communities. We have about 100 physicians in our physician group made up of family practice, urgent care, occupational health, cardiology, pulmonology, oncology, pediatrics, employee health, and the list goes on. But my group, again, is just charged with those working with employers and community partners in the region. And as a part of that, we've kind of led that telemedicine strategy for our health system. So a little bit about Mercy's telemedicine journey started about in 2012. And at that time, there was a lot of equipment out there, a lot of networks that you could purchase. There was just a lot of different options to go with. And we decided at that time to partner with Cisco to purchase their telemedicine network. And also we purchased some carts that were made by Cisco as well. Those have now been transitioned to Avizia. But we still have a couple of those carts. And we worked with AMD and their diagnostic gear as well as their Agnes products. So what we did back in 2012 is we knew that there was this trend towards direct-to-consumer care and convenience for patients. And being that we were in Iowa, we knew that there would be a rural component of any strategy that we might employ, and there'd be very different use cases that we may use. But what we decided was to partner with Cisco, and we procured the technology and then really started playing with it. We really didn't have a use case. We had many use case scenario ideas, but as with anything, we really needed to test them out and make sure they were going to work for our business and our operational workflow, for our clinic system, our providers, but also that they made sense from a reimbursement and licensure perspective. So we ended up purchasing that equipment and started testing out use cases, demoing for different community partners to get other ideas of how this technology could be adapted to help businesses, employers, smaller health systems. Just there were a lot of ideas that were generated during that time. And really kind of where we've ended up is, as of today, we have 2 telemedicine solutions that have been implemented over the last year, and we continue to develop other use case scenarios and other options for using the equipment. Our first telehealth clinic opened in April of 2015, and it was at Rockwell Collins. So if you're not familiar with Rockwell Collins, it's a global company in about 150 countries. They have about 20,000 employees, and their headquarters is actually in Cedar Rapids, Iowa. So they are the largest employer here in Cedar Rapids. There's about 8,700 employees that reside in this community. And so we have our on-site telehealth clinic at on their campus. It's next to an on-site pharmacy that they have. And we've been open since April, and our volume continues to grow. And we've partnered with Rockwell to offer, actually we partnered with Rockwell and our one of our biggest state insurers, which is Wellmark Blue Cross Blue Shield, to get this paid for. And we also partnered with the Iowa Board of Medicine to make sure that this was, as we were deploying this clinic, they were also developing their rules in terms of telemedicine. And so we kind of went side by side with them, making sure that we were in line with everything that they were developing at that time. So the use case is compliant with the Board of Medicine. It's reimbursed by Wellmark for the Rockwell employees who have a high deductible health plan. So it's been a great clinic, and the patient satisfaction is 99th percentile measured by Press Caney. Every single patient that comes through gets a survey. And by word of mouth, our volume continues to grow every single month. You'll learn more about that scenario and our Edgewood Hy-Vee scenario that can be applied to rural environments a little bit later on. The second clinic that we opened is within a grocer in town, Hy-Vee, which actually they have 240 stores in 8 Midwestern states, and they have locations in many rural communities. So we partnered with Hy-Vee. This is our first clinic with Hy-Vee. It's a one-room clinic that has a small lab, a restroom, and a check-in station. We have a registered nurse that's on site there, and as you can see in the picture here, Kara, who you're going to hear from later, is on the left-hand side of the slide. She's actually doing a visit. That's her provider workstation, and on the right is the patient endpoint, where the registered nurse and the patient reside. So you'll learn a little bit more about these use cases, but our Edgewood Hy-Vee locations opened in November, and that's our first telemedicine clinic that's been open to the public. And so there's some challenges with reimbursement that we work through every day, but there are insurers that do pay for this clinical telemedicine encounter. And this is a really great example of how it could be used in a rural environment where maybe there's a shortage of primary care or urgent care resources that could be maybe in a larger nearby region where you could set up a telemedicine station similar to what you see on the right-hand side for patients to receive health care. So wanted to kind of walk you through what we thought about when we were building these two use case scenarios at Rockwell and Hy-Vee. The first important piece that you need within a health system, if you're looking at deploying this technology, is that you need to have physician buy-in or provider buy-in. It helps to have a physician lead the charge for getting other physicians to be on board with delivering medicine via telemedicine and being comfortable with the encounter with the patient via that technology. We do have Dr. Tim Segers. It was the leader who really brought telemedicine or introduced telemedicine to our organization and helped our primary care and urgent care physicians and mid-level providers be on board with this healthcare delivery model. The second that you want to be aware of is consumer buy-in and their satisfaction. We wanted to really understand our customers here as well, so it's important to talk to those customers and make sure you know what they want. And then when you actually implement the solution, you want to make sure that you're delivering to their expectations. So we really we got a lot of data from our customer and then decided when we rolled out these two use cases that we wanted to make it very kind of almost a transition from a normal office visit with a provider that's there in person to a totally direct-to-consumer model where the patient is the only one on the patient endpoint and the provider's on the other side. It's really, these two use cases that we have now are a nice transition for our consumers in Iowa because it looks and feels like an exam room. There's an exam bed, there's, a scale, there's a blood pressure cuff, there's everything that you would expect in a doctor's office is sitting in that room. The only difference is that you're seeing the provider on the screen rather than in person. So that really, I think, has helped with the utilization and buy-in from our consumers. The third thing you need to think about is an efficient workflow for patients, nurses, and providers. So we wanted to make sure that it was seamless, that when the patient walked up, they were checked in similarly to how they would in an office environment, and that the information that we obtain, we're able to bill to insurance or collect at time of service. We wanted to make sure that the nurse was trained just like they are in our other clinics. They're able to take the patient back, get their vitals, and put those vitals into our Epic electronic health record. So the beauty of these two use cases is that we have our Mercy network at these sites, and these nurses have access to our electronic health record just like they do in any other clinic. So they're able to put in that chief complaint, those vitals, allergies, medications into the record, and the provider on the other end is able to see all of that information real time. So it's very efficient for both sides because that communication exchange is real time. When the patient has, they've had their vitals taken and it's time to notify the provider, we want to make sure that that's an efficient way too, because some of these providers have other things that they're doing during the day, and so we needed a good way to notify them so that they knew it was time to go to the provider workstation and call the clinic via telemedicine. And then we also wanted to make sure that we could send prescriptions and we could do after visit summaries and all these things that we do in our normal workflow. So we wanted to make it very easy for patients, the nurses that work there, and the providers. The fourth thing is the IT infrastructure. You want to make sure that you really, really understand how that works. In our case, we decided to have our Mercy network out at these endpoint locations so that the same firewalls and protections are out there as they would anywhere else. It was really important for us to make sure that our patients' privacy and any personal health information was protected. Also, you want to make sure that you test the bandwidth that you're using when you are doing these encounters to make sure that there is enough bandwidth on the network so that so it doesn't compromise the quality of video. But then we also wanted to make sure that we were constantly just monitoring that to make sure that we didn't overdo it at times. So I remember testing for some of these locations and turning on every single computer, trying to do WebExes, doing 2 telemedicine visits, and really trying to max it out to see how bad or how many things can we get on this network before quality starts to diminish. You just want to make sure you test those scenarios out, because you don't want a patient sitting down for an exam and then having to turn them away because you're not able to complete that exam. And thankfully, we haven't had to do that up to this point. Another thing that you want to think about is really the continuity of care between your patient endpoint, your provider endpoint, and the patient's primary care provider. Because we have the shared electronic health record, that's very easy to obtain that between the patient endpoint and provider endpoint. But also, per the Iowa Board of Medicine, it's important that we also are communicating with every patient's primary care provider so that we can help with that medical home. So if the patient is a Mercy patient and they do come to one of these clinics, it's really great because we have our health record has our hospital, urgent cares, primary care clinics, emergency room is all on one system. So we're able to see the complete picture of the patient. And because our neighboring towns of Iowa City, where the University of Iowa Hospitals and Clinics is, and also our competitor Unity Point, we all share the same Epic electronic system. We all have our instances of it at each site, but we can tap into each system with consent from the patient to see those records. But the primary care provider communication is important to the Iowa Board of Medicine as well, as that's part of our rules. Robust training is something you want to think about. At all of our endpoints, we have registered nurses who are our telepresenters, and they really are the hands of the provider who's at the provider endpoint. So they need to be very well trained and have a good relationship with those providers, because they're going to be doing portions of the physical exam on behalf of the provider. So we wanted to make sure that they felt comfortable with instructions from the provider via video, and that they're well trained in physical exam components and directives. On the providers, it's important for them to have training as well, because they have to make sure that they're looking at the camera, or looking at the camera instead of the monitor. I don't know if you've ever tried to have a conversation on FaceTime, but it always seems like you're looking in the wrong direction when you're looking at your screen. So we wanted to make sure that providers understood how they looked when they are on camera and where their eyes should be focused. Also talking through the physical exam and instructing the nurse, and just having those good communication skills via video is quite a different experience than in person. I've talked about the clear follow-up and after visit summary, but we are doing 2-day follow-up phone calls to all the patients that visit our telehealth clinics, just to make sure that everything's okay and that they haven't had any further issues. We just want to make sure that we're not causing higher utilization than need to be. So we really want these to be a convenient but a high quality experience for these patients. something I mentioned before is really the licensure, the Board of Medicine. Just in your state, making sure that you're aware of all the rules that exist in terms of the Board of Medicine, how that physician-patient relationship is established, and how to obtain that patient consent. Those are all really important items to consider. There is a compact that's been initiated by many states in the country to honor each other's licensure, so that physicians who are in the state of Iowa and want to practice in Minnesota, that it would be more of an easier process to obtain those licensures to be able to see those patients. So I think more is to come in that regard. The other thing is reimbursement. Checking your state laws in regard to reimbursement. Some states have parity laws that allow for reimbursement. There's some that don't. Some, they might have a parity law, but each insurer interprets that a little differently and has a different policy of how to meet those requirements. So you really need to understand your payer mix and what types of information you need to make sure that you get. Medicare has a pretty restrictive policy, but in terms of rural health, it is very generous. So if you are in a rural community, you definitely check out the Medicare laws, because those are really there to benefit those rural communities. Another important thing is reporting. Once you do get a use case or you implement one of these use cases, make sure that you're looking at all of your metrics, whether that's patient satisfaction, staff satisfaction, quality metrics, follow-up metrics, number of visits, utilization, provider satisfaction. So there's lots of things that you need to kind of think about while you're implementing a use case, and items that you need to consider that you should be monitoring to make sure that it's actually working. Because the last thing you want to do is implement something that fails. So here, this is kind of a transition to the Stephanie Cooper, who's the manager for Mercy Care Business Health Solutions. She's actually going to talk a little bit more about the Mercy Care Telehealth Clinic at the Edgewood Hy-Vee location. Thank you.
Thanks, Brooke. Good afternoon, everyone. As Brooke said, I work on the business health team and manage our 2 telehealth clinics at Rockwell and our Edgewood Road Hy-Vee. As Brooke said, we opened in November, and one of the things that we felt was important with both of these clinics that we do staff with a registered nurse. And there's a couple reasons for that. When a patient comes in for a visit, there are obviously some things that we cannot see via telehealth. So we really wanted the nurse to be able to triage with those patients, and if it wasn't appropriate for telehealth, to be able to help direct them to the right level of care. In addition to that, because the person on site is really the hands of the provider, we felt it important that they were a nurse that had some of those assessment skills and those critical thinking skills, that they could help communicate those things to the provider as well. Our clinic there at Hy-Vee is covered by a pool of local Mercy Care providers. So we have providers throughout our system who may be seeing patients in their office, family practice providers, or possibly urgent care providers. And rather than go into an exam room and see the patient on site, when we have a patient there at Hy-Vee, they go into the designated telehealth room and log in and see the patient via video. So it's really worked out well to have that pool of providers. We utilize Epic for our electronic health record, and so when the patient comes in, the nurse there on site registers the patient, collects insurance and payment, and then they go ahead and take them into the exam room. And very similar to any other clinic visit, they go ahead and get their vital signs, collect their medications, allergies, past medical history, and that's documented in Epic, so the provider, wherever they may be sitting, can log in and see that information. As I mentioned, these are a set diagnosis list that we work with, and really it's more those urgent care walk-in visits. We see the coughs and the colds and the flus, skin issues, urinary problems, also strains and sprains. And when we started this, we thought we might be fairly limited, but we found that we're able to really see a lot of different types of illnesses and injuries through telehealth. We do have some point-of-care testing on site. We're able to do strep, mono, flu, urine tests right there. Our nurses follow some standing orders, so they're able to perform those tests prior to the provider even coming online. So they have those results ready when the provider does log in and video in to see the patient. At our Rockwell location, we do have a full lab on site. Just because of space interest here at Hy-Vee, we don't, but that's certainly a possibility. We have a lab on site that we're able to perform those testing and send them to our hospital for processing. Within our location here at Hy-Vee, we do have a pharmacy literally right next door. So providers have the ability to send electronic prescriptions. They can send those anywhere that the patient would like. Obviously, it's the convenience factor with having the Hy-Vee pharmacy right there. As Brooke mentioned, there are several metrics that we track with our telehealth clinics, and the satisfaction is a big one. We utilize Press Ganey for our patient surveys, and those survey results have been very high, and part of the reason for that is that this is a very interactive visit. Not many people have seen the inside of their ear before, or they haven't seen down their throat. So it's kind of neat for them to be able to see that, and then when the provider is discussing their treatment plan, they understand it a little better when they say, you know, that's really red, you know, infected, inflamed, this is what we're going to treat you for. So that's been a great patient satisfier. These are usually quick visits as well, and, you know, hopefully in and out. Nurse satisfaction is also high. This is a little bit different visit because the nurse is in the room the entire portion, and they're listening to the provider and are learning, you know, what they're sharing with the patient. That way, when the provider drops off the other end, the visit's over, the nurse can help continue to educate the patient, provide the discharge instructions, and answer any questions. And Kara will talk a little bit more about provider satisfaction, but it certainly has been well received within our organization. Some of the quality metrics that we follow, again, like any other clinic, we want to make sure that we're giving high quality care. We monitor blood pressure management. We follow up on immunizations. We do NICU assessments. Track to see if patients have a designated primary care provider. We really encourage that, and we'll help patients find a PCP if they don't already have one. In addition to the Press Ganey, we do 2-day follow-up phone calls to our patients. Because this is a new type of visit, we want to make sure that they were satisfied, but also if they have any questions that need to be addressed, or if there's anything further that we can do for them. So that certainly has helped patient satisfaction as well. We track diagnoses. We want to know what kind of diagnoses are coming into these clinics. That's important for utilization and to know you know, if there's anything that we need to change. But as I mentioned, the coughs, the colds, the flus, skin, urine, those are kind of the main things that we see. And reutilization is big too. We want patients to be satisfied. We want them to feel that they got the most out of their visits, and we want them to return. So we track reutilization of patients, and a lot of times we're seeing them bring their family members in as well. One of the things that I did not mention, currently we have kind of set the age limit for these telehealth visits at about age 5. And the reason for that is that with the nurse being the only one there on site, they're handling the diagnostic equipment. And so sometimes if you've got a little toddler, it may be hard to kind of keep a hand on them and the equipment. We've certainly done some kiddos younger than 5, but that's kind of been our baseline, and that seems to work well. These are the 2 use cases that we are currently utilizing, and as Brooke said earlier, we've investigated several other areas, and I'll kind of talk through a few of those. Workers' compensation, triage, and follow-up. We've worked with employers in our community and know that you know, it's very difficult to sometimes, if they're in outlying areas, get employees in for treatment following a work injury. And so we're looking at a triage system that may be able to access a provider to say, yes, you need treatment right away, you know, come to the emergency room, or let's try this and maybe follow up with OCHealth tomorrow. The other thing that we can do along those lines too, we think, is that work comp follow-up. A lot of times that's a discussion with the patient and some information about pain and how they're, you know, utilizing any devices, that type of thing. So we think that can certainly be done via telehealth. In Iowa, we certainly have a shortage of psychologists and psychiatrists, as I know several others across the country. So EAP and counseling service is of great interest to us and how we can utilize telehealth to reach more people in our community. Provider-controlled follow-up. We've worked with several of our Mercy Care providers. Once a patient has their medical home, their PCP, they may need to return for those diabetes follow-up visits or to monitor blood pressure, those kinds of things. So some of those visits can be done via telehealth, and that's really communicated between the provider and the patient, and they can kind of determine that up front if telehealth is the right option for that. Nursing home visits. With providers being in multiple places, sometimes getting to those nursing homes can be difficult. So we may be able to use telehealth to do some of those follow-up visits. We've looked into school-based health centers. Obviously, we want to make sure that our children in the community are getting the care they need. So some on-site health centers would benefit the kids, but also the teachers and employees at the schools. They may not need to leave work. They can go to a clinic right there on site and utilize telehealth. Diabetic education and dietitian counseling can certainly also be utilizing telehealth. These things that can be done, to a patient at a different location, and certainly looked at in the future home as well. So those are some of the use case scenarios. We know that there's lots more out there, and we're excited to grow our program with some of these things. So I'm going to turn it over to Kira Goslin. She is a PA that has really done a lot with both of our telehealth clinics, and she will talk about the workflow.
Thanks, Stephanie. Hello, everyone. I'm basically going to talk a little bit about the patient visit workflow and how it tends to work. In the clinics that we have, the patients typically walk in. We do encourage them to schedule ahead of time, but oftentimes, it's kind of the spur of the moment. They just walk into the clinic. The nurse greets them at the front desk. She obtains all of their, insurance information. They talk about the chief complaint, just so that the nurse knows whether or not the patient is appropriate for telehealth. If the patient is found to have a complaint that is appropriate, they're placed on a schedule, and then the provider at their endpoint is able to see that. The nurses go ahead and obtain and document the vitals, the chief complaint, the meds and the allergies, and then they go ahead and flag the patient as ready for the provider. And that is basically a cue for the provider on the other end that the patient is ready to be visited or examined. The provider has 3 screens. You have a main screen to speak to the patient directly. There is a screen for the electronic medical record that the provider would be documenting the patient's history and their complaint. And there's also a screen for viewing the diagnostic camera. The nurse does remain in the room during the visit. The HPI is obtained by the provider, but the physical exam is a collaborative effort between the provider, the nurse, and the patient. The provider, basically, I would instruct the nurse to use specific diagnostic tools to obtain the information that will assist, for me to diagnose the patient. As Steph previously mentioned, we have a point of care testing lab on site that can be completed, and those results are able to be accessed by me prior to even seeing the patient. Once a diagnosis has been made, the prescription is sent electronically to the pharmacy of the patient's choice, and an after-visit summary that basically details what the patient might expect during the course of their treatment, reasons to return, and just some basic information about medications and possibly interactions can be printed out for the patient. And once the provider disconnects, the nurse is able to go over that before letting the patient, leave the clinic. Nursing perspective has been good. I think that the nursing staff is happy to be able to develop a broader knowledge base than they otherwise would in a traditional clinic, because they are present for the entire visit with the provider and the patient in the room. So not only are they able to, see everything that I see, but they're able to listen to the explanations that I'm providing to the patients and the questions and answers that the patient and I are talking through towards the end of the visit. From a provider's perspective, telemedicine is fantastic. I mean, it's pretty cool to be on the cutting edge of this technology. It does provide, an opportunity for a single provider to see patients at multiple facilities, which, as we all know, is valuable since there's a shortage of primary care providers. So thank you.
Thank you. And before we quickly open it up to the Q&A session, we thought it would be helpful to quickly list some additional examples of how clinical telemedicine is being used in rural health applications. And many of these were actually just touched on as well by Mercy Care. So telemedicine used to be seen kind of as a futuristic technology to people, and many that were using it were just testing it out. But today, everywhere you look, there are proven applications of telemedicine being used as a tool to deliver healthcare. So these are just, some examples of places that our customers are using telemedicine technology. Obviously, community clinics, which we kind of went through as a use case with Mercy Care, school systems to provide healthcare access to children, rural hospitals to increase the physician utilization and bring specialists to smaller community hospitals. Obviously, telemedicine in long-term care or nursing home facility helps eliminate the need to go back for a follow-up appointment or reduce hospital readmissions. Telemedicine in patient homes, so bringing clinical telemedicine to the home for follow-up visits, so patients can be seen in their home instead of having to leave for an appointment. Telemedicine in medical missions, treating patients in areas that are underserved and getting top specialists to treat those patients. So just as a reminder again, we do have some questions, but if you would like to type in questions now, feel free to do so on the panel on the right-hand side, the question box. You can enter them there. So let me just look here. Let's start reviewing. We'll get through as many as we can. I know we have about 10 minutes left for the webinar. So let's see. Okay, so the doctor has access to consultation via web browser, or it needs to have licensed software interface installed in the PC. Riley, do you want to respond to that one?
Sure. I'm sorry, Carrie. Could you repeat that?
Sure. Does the doctor have access to the consultation via web browser, or do they need to have licensed software interface installed on their PC?
So the way that we did it during the demonstration is the doctor needs nothing more than a web browser. The AMD processes, there are no costs for the doctor side of our Agnes product. So only a web browser.
Okay, thank you. Let's see. Sorry, there's quite a few questions here to go through. Okay. If a distant clinician wants to have a look at a case at a later time, where will the consultation data be saved? In the device or in a cloud, or do we need to take additional server-based functionality?
So they can do it either way. It can be stored in a cloud by a product that AMD provides, Telehealth Consult, or if they already have their own patient record system, the Agnes software can communicate and push all the examination data to their existing medical record.
Okay, thank you, Brad. Brooke, I think this is for your team to speak on. In Iowa, will insurers reimburse telemedicine visits that originate from a pharmacy if a pharmacy tech presents the patient?
Each insurer is a little bit different. What I would encourage you to do is to look at the CMS website. They have clear guidelines for telehealth, and most insurers do reference those rules when developing their own. I can tell you for Wellmark Blue Cross Blue Shield, the originating sites that are authorized are the Office of a Physician or Practitioner, a hospital, inpatient or outpatient, a critical access hospital, a hospital-based or critical access hospital-based renal dialysis center, a skilled nursing facility, and a community health center. So that is where the patient would be, is in one of those locations. And then the telemedicine services could be provided by a physician, a nurse practitioner, a physician's assistant, a nurse midwife, a clinical nurse specialist, a clinical psychologist, a clinical social worker, a registered dietitian or nutrition professional, and a licensed mental health counselor. So I would really encourage you to look at those before you jump into anything, just to make sure that you comply with those protocols for reimbursement. But I'd also encourage those of you on the line to go to the American Telemedicine Association website. They have a lot of resources and state-by-state comparisons of different reimbursement laws, Board of Medicine rules in each state, and can give you a great picture of what you're up against in your specific state.
Great. This is also for your team. Brooke, how do you deal with prescriptions?
Kara, I'll let you actually take that question.
So prescriptions, I mean, obviously we don't prescribe any narcotic or scheduled medications that require a physician's signature. But any other prescription is just, we have a prescription program in our electronic medical record that can associate a medication to a diagnosis, and you're able to put in the name of the medication, the dose, the duration, the number of quantity of medications that you want to give the patient, and then typically I'm able to scroll through a list of pharmacies. So I'll ask each patient, do you have a preference for where you'd like your prescription to be sent? Fortunately for us, both of the clinics that we currently have, there are pharmacies kind of right there on site. And so the majority of our patients have their prescriptions sent directly to those pharmacies, but you know, I could send a prescription anywhere in the country. Hopefully that answers the question.
Okay, great. If the nurse does not determine the patient is appropriate for a provider visit, how do they process the patient?
Steph, do you want to go ahead and take that one?
Yeah, I can take that. So when the patient comes, we certainly, you know, discuss what their chief complaint is, and if we don't feel that they're appropriate for telehealth, and sometimes determining that is really discussing with the provider as well. But then we offer them some other options, whether it be an urgent care or an emergency room, and certainly we work with patients to get a primary care provider too. Now, if we do get a patient in and we felt like, you know, when they came into the clinic initially, we felt like this was going to be appropriate, but we get them back in the room and we're learning more information about them. If we get down that road and feel like, you know, they really need a higher level of care, we will not charge the patient for that visit, but again, help them determine where they need to go from there.
Okay, great. Also for Mercy Care, how do the providers in your pool incorporate these visits within their clinic day?
I can go ahead and take that. So we actually use different provider pools for both of these clinics, and I think we continually analyze kind of what's the best way to tackle provider coverage. As many of you know that probably are from health systems on the phone, that's kind of always the question mark of, you know, you want to provide good service, but you don't want to have an expensive resource just waiting for patients to come. So in some of our use case scenarios, we have a 0.6 provider coverage that can help in a dual role at their site. And then we backfill with provider pools in our system that have some capacity. To be quite honest, this is a great use case for those primary care providers that might be building a practice. Hooking up one of these clinics to a provider that's building a practice is a great way to keep them busy, but a great way for them to meet new patients and get them into their medical home. So we have different types of provider schedules. We also have one of them hooked up to an urgent care that maybe isn't as busy as some of our other urgent cares. So there's quite a wealth of different ways to do this, and it just is all about creativity.
Great. Okay, this is good. If insurance doesn't pay for the telemedicine visit, do you charge for the patient visit or write it off?
So in the Rockwell Collins Clinic, that specific use case is covered, so we don't really have to worry about it in that instance. For the direct-to-public Hy-Vee telemedicine clinic, we do have a charge, an upfront charge that we do collect at time of service. unless the patient has the insurance plans that we know cover the service. So it's a lesser charge than what they would experience in an urgent care or from a primary care provider, and at that point, most patients are looking for convenience and actually will pay for that up front. So it is more of a retail model. So I hope that answers the question.
Sure. Just another question. What is the highest level of visit that can be seen at Hy-Vee?
I'm not sure what exactly highest level of visit means in that question. Kara, do you have any feedback on that? I'm not sure if that's in terms of coding or level of acuity.
Right. I think that it would probably have to do with not only the level of acuity, but also the billing. Typically, I would say that most of these patients are 4s and 5s, if that makes any sense, in the triage kind of hierarchy that we would have like in an emergency department. But we are able to see some soft level 3s as well. You know, we haven't really been able to, I guess we've been surprised by the amount of what we have been able to see. And every day, you know, I am impressed with, you know, different patients that come in and the ability that we have to see those patients and accommodate their needs. So, yeah, hopefully that answers the question.
Okay. What is your ROI for the patient visit via telemedicine if you have this data?
We're still working through those because for each specific use case, it's a little bit different. When you're working with an employer and an insurance company directly, and say the employer is self-insured, there's a different type of ROI that you would work through for that use case scenario versus the telemedicine clinic at Hy-Vee. But what I can tell you about the telemedicine clinic at Hy-Vee is that it is a whole lot more cost-effective to have a registered nurse on site with a small footprint of a clinic space waiting for patients than it is to have a nurse practitioner, a physician assistant, or a primary care provider or MD that's sitting in that space waiting for patients. So the cost structure is quite a bit lower when you're working with that type of use case. What I will say is that you want to work very hard with your insurance companies and partners in the community to make sure that the providers that you're getting paid for what you would get paid for a traditional office visit. The diagnoses is still the same. Treatment plan doesn't differ. It's the same level of service that the patient is getting, except for they aren't being touched, but they're getting the same outcome. So I really think that for these clinical telemedicine encounters that you should fight for them to be paid like you would for any other visit that you would see.
Okay, and I know we're getting close to the end time, so this will be the last question. We have a question on staffing within your telemedicine department and what positions you have there. So what's the staffing like? What do you have on staff?
Steph, do you want to take that?
I can take that, Brooke. Yeah. At Hy-Vee, we just staff with one nurse. So the nurse does everything from check-in to registering the patient, you know, entering insurance, taking co-payments. They take the patient into the exam room, do any point-of-care testing, and do the checkout. So we just staff with one nurse. At Rockwell, we have 2 exam rooms and a lab, so we usually have 2 nurses on site there. But really, it's a little bit different model for the nurse, and there's some additional training to go into that registration and kind of learning the insurance as well.
Great. Okay, that wraps up our Q&A session for now. We did have quite a few more questions, so we'll try to address the rest of the questions in a follow-up email end of this week or early next week. Here's the contact information for each of the presenters today for the webinar. If you wish to, you can also send a follow-up email to any of the presenters with some questions you might have. And then we will be sending out a recording of the webinar as well as a copy of the slides within 48 hours. Thank you for attending today.